All right, here we go with Chapter 15, Part 2. We're going to focus on characteristics of adult dysphagia. The defining characteristics of adult dysphagia typically relate to the following: the phase of the swallow affected, so is the oral prep phase, the oral phase, etc. What's the underlying pathology or cause of the dysphagia? And what's the severity of the dysphagia? Dysphagia can be characterized by the phase affected to identify the site at which the swallowing system breaks down. The SLP is primarily concerned with disorders in the oral prep phase, the oral phase, and the pharyngeal phase. As we get more and more technology, though, we're also being increasingly consulted on and working on problems in the esophageal phase as well. All right, the oral prep phase. Decreased lip closure is a big issue, resulting in problems intaking foods or liquid from an eating utensil, straw, or cup. Right, if you can't close your mouth around that spoon or that fork, right, or the cup, you're going to have food spilling all over the place. And then once you get food in your mouth, if you can't close your mouth, you're going to start those materials are going to leak back out of your mouth. So you're just going to have a difficult time getting food in your mouth, and then once it's in your mouth, having them stay in your mouth and not leaking out of your mouth. Also, problems controlling the ingested materials such that food or liquid falls in the space between the teeth and gums, and that area is called the sulci. So, right, they have a hard time forming that food into a bolus, which we'll talk about in a second too, and then food starts to fall into that area between your teeth and gums, and then they might not have the tongue mobility to sweep it out of there. They might not have the sensitivity to even know it's in there, and then food just kind of sticks in there. And then, right, the bad thing is if food then stays in your mouth, you could be, it could start going to the back of your mouth, and you could start aspirating it rather than swallowing it. Also, difficulty biting or chewing, thus hindering the formation of a bolus, right? So if you can't bite, if you can't chew, problems with your teeth, problems with your mobility of your mouth, that bolus is going to be really not formed well. You're going to have a hard time moving it back and forward and what you want to do with it. A reduced range of motion of the tongue and or weakness of the tongue, requiring increased time to prepare the bolus for swallowing. So again, you can't sweep your mouth to get all the food to form it into a bolus, and then it might take a long time to prepare the bolus and then to move the bolus from the front of your mouth to the back of your mouth, right? And then also impaired sensitivity of the tongue, lips, and other oral structures are going to hinder food positioning and management, right? So if you don't realize that you've got food in between your teeth, food in between your teeth and your gums, you've got food stuck up on your hard palate, right? All of a sudden that food's going to stick there, and you're going to have a hard time moving it and doing what you want to do with it. All right, oral phase, difficulty moving the bolus to the pharynx, resulting in food or liquid residuals remaining in the mouth. So typically in the sulci or adhering to the hard palate. So again, food gets stuck, it stays there, you're not actually forming it into the bolus. An inability to adequately control the bolus flow such that some materials spill into the pharyngeal region prematurely, right? So all of a sudden you've got food in the very back of your mouth that you're not ready to have back there, and that can lead to choking, and aspiration. Delayed initiation of the bolus movement, increasing the transit time from the oral to the pharyngeal phase. So if it takes you a long time to get the bolus formed, and then the bolus is there and ready, but you're not moving it from the front of your mouth to the back of your mouth, more bad things can happen the longer it takes to get that food ready. The pharyngeal phase, incomplete palatal elevation to seal off the nose from the pharynx, allowing foods or liquids up into the nasal cavity, causing nasal reflux. Delayed initiation of the pharyngeal swallow reflex, allowing materials to move deeper into the pharynx or larynx, thus increasing the risk of aspiration. So you've got food in the back of your throat. You should be swallowing. You're not swallowing. Is it going to fall into your airway as it takes a long time for you to begin that swallow motion? Diminished tongue and pharyngeal muscle force to move the bolus through the pharynx, resulting in materials hanging in the throat. So maybe you swallow, but you only get part of the bolus down. You've got extra food in there, stays in there, and again, that could go into your airway. Reduce laryngeal elevation and closure, making the airway more prone to entering materials, aspiration, right? So you're not elevating your larynx up high enough. And so again, more food's going to stick in there, not go down the right way, and it could go into the airway. Inadequate opening of the cricopharyngeus muscle, the upper esophageal sphincter, hindering the movement of the bolus into the esophagus and enabling the retention of food residuals within the pharynx, right? So a lot of this is just in your swallows, inefficient, it's not complete. Food stays in the back of your throat rather than being swallowed down. And that food that stays there, right, you're going to start breathing eventually after that swallow's done, and that could fall down into your airway. Underlying pathology or cause. Dysphagia is a secondary disorder, remember, meaning that it results from another primary cause. Common causes of dysphagia are neurological damage due to a stroke, a brain injury, or a disease such as Parkinson's, and also laryngeal damage due to radiation, surgical removal of the larynx, a laryngectomy, or trauma. Stroke is a leading cause of disability and death among adults. The percentage of those developing dysphagia following stroke is at least 50%. Traumatic brain injuries are caused by car accidents, falls, and physical acts of violence, and often result in diffuse brain damage. So, brain damage all over the brain. 1/4 to 3/4 of individuals with a traumatic brain injury will experience dysphagia, right? That's a big range, that 1/4 to 3/4. And that's depending on how you define traumatic brain injury, how you define dysphagia. But at least half of people that have a stroke have dysphagia, and at least 1/4 of people who get TBIs end up having dysphagia for at least a period of time. Progressive neurological diseases are disorders of the nervous system and producing discoordination and weakness of motor skills, as well as decreased sensory abilities, right? So both decrease of motor skills and decreased sensory abilities can lead to dysphagia. Some of the biggies for the elderly are going to be Parkinson's disease, ALS, and dementia. We've also got head and neck cancer treatments. So cancerous growths of the mouth, pharynx, and larynx are treated with surgery, radiation, and or chemotherapy. Dysphagia is often present prior to medical treatment for these cancers, but it frequently becomes much more severe following the intervention. So the interventions can help the cancer, but it makes the dysphagia worse. Head and neck cancers often result in oral or pharyngeal stage dysphagia, which can be readily managed for many individuals. So, as long as the person is still neurologically, intellectually intact, there's lots of things we can do to increase and improve swallowing. But it can be a hard battle. So just remember, if you're a smoker, if you're using chewing tobacco, really consider not doing that. The severity of dysphagia can range from mild to severe. The penetration aspiration scale uses an 8-point scale to describe the degree of airway protection during the swallow. A score of 1 indicates that no material enters the airway, whereas a score of 8 indicates that material is aspirated and the individual shows no effort to cough and no gag reflex, right? So not only are we aspirating, but there's no effort to get that food out of there. A patient with a score of 8 is at very high risk for aspiration. The clinical swallowing exam. The SLP will often conduct a clinical swallowing exam and do a bedside swallow exam. So this will include review of current and past medical records, a comprehensive client interview to learn medical, social, family history, and the history of the swallowing problem. When did it start? What foods are most troublesome? What foods don't cause problems? A thorough oral mechanism examination of the mouth and throat to determine structural and functional adequacy for swallowing. We can do trial feedings or observation of the client during a meal, and we can make feeding recommendations if appropriate. We can also refer the client for instrumental assessment of swallowing if indicated. We'll talk about that in a second. And to refer the client to other professionals for any specialized testing that is needed. So occupational therapy, physical therapy, anything else that they might need for that. All right, so let's talk about instrumental dysphagia examination. All right, so evaluation of swallowing problems using technology or instrumentation typically provides a more objective and quantifiable measure of swallowing functions, including the safety of those functions than the bedside examination. All right, so if you're doing the bedside exam, you're talking to the person, you're watching them eat, you're looking at their tongue, their hard palate, their soft palate, things like that, but you really can't see what happens with the food, right? You can see them cough, you can see them eating easily, maybe, but you can't really see inside their mouth very well while they're eating. So there are a couple ways to do that. One is a fiber optic endoscopic examination. So you get a little thread with a camera that goes up the person's nose and down into their throat. And you can really see the food as it's in their mouth, in the back of their throat. But once it's swallowed, you can't see it anymore. So it gives you a good view of the oral prep phase and the oral phase. Everything else is difficult to see. You can use an ultrasound. And an ultrasound allows you to take an ultrasound of the mouth and the throat, and you get to see that swallow a little bit better. But with an ultrasound, you've got the bones in the way. It can be really hard to see what's going on. If anybody's seen an ultrasound of a baby, right, you can kind of see the baby, you can kind of see things, but it's not great. Really, the gold standard is the video fluoroscopy, which is like a real-time X-ray machine where you can really watch the food go into the mouth, the food be pushed back into the bolus, the food being swallowed, what happens with the food, if it's going down the right way or the wrong way. So the video fluoroscopy is really the gold standard right now of care or of assessment. Treating dysphagia. Following assessment, the speech-language pathologist often provides direct treatment to remediate dysphagia using 2 types of rehabilitation strategies. So one would be compensatory approaches. So we can look at what the person's eating. So do they have a hard time with liquids? Do they have a hard time with solids? Right? Can we make liquids thicker? Can we put a thickening agent in their liquids so that they have an easier time? If they can handle solids well, that can solve the problem, but it's not great to, have thickened liquids. It doesn't taste good. Often patients won't drink as much. So we've got to worry about that. And then there are also things we can do. We can do a chin tuck swallow where we teach patients to touch their chest with their chin. When they're swallowing, that can open up that area and really help them swallow more effectively. We can teach them things to do with their tongue. We can teach them, maybe they can turn to their left or their right while they're swallowing, depending on where they're having trouble. So there are a lot of compensatory approaches we can do to try to make swallowing easier and safer. There are also restorative techniques where we can actually work on the client swallowing, teach them how to do a harder swallow, and over time they can practice swallowing, and for some people that can make a big difference. All right, and then we get nutrition and dietary considerations. The importance of nutritional health to an individual with dysphagia cannot be overestimated. Because dysphagia results from an underlying disease, individuals must achieve adequate nutrition to promote healing of and recovery from the underlying disease. For example, people recovering from neurological injuries such as stroke or traumatic brain injury have greater nutritional needs than they did prior to their illness, right? So we've got somebody who, has another thing going on, either stroke, TBI, they really need nutrition to heal. And if they have dysphagia, they can't heal as well. So getting them to eat and get nutrition as quickly and as well as possible is really important for their whole individual and the whole healing process. And something we haven't talked about just to end up here is a lot of people really enjoy doing feeding and swallowing work. They get to see huge changes in people, helping them eat, helping them swallow. And it's a great way for people to work in hospitals, doing something really medical, really changing people's lives without having to go on to get your MD. So it can be really rewarding work, and a lot of people really enjoy it. And that is the end of chapter 15.